This is cuneiform, which you might recognize. And it's a beautiful registered thing. It's done by the Babylonian society, by Babylonian astronomers. And already in like 360 BC, what they did is they recorded the movement of Jupiter across the skies, which is a pretty complicated movement over time. So what they did over many, many years, they recorded data. They registered the data, and then they somehow applied what we would call nowadays data analytics, quite advanced methods to unravel the dynamics of Jupiter moving across the skies. And even before that, as was registered in the Dresden Codex, the Mayan astronomers, they looked at the movement of Venus, and they were able to unravel the 584 days of cycle of Venus and predict with a 2-hour accuracy the way Venus would appear across the skies. An amazing feat at that time that they were able to do that. They dug into tons of data for many, many years of astronomical observations. But if you think about this, so yes, they did. They did manage to actually predict how things were going. But if you think about what their vision of the world was, then the Babylonians, they actually thought that the world was a flat disk floating in the ocean. And the Mayans, they thought the earth was a flat disk held up by 4 jaguars. Now here is a lesson. And the lesson is that data doesn't tell you the story. Not just like that. The lesson is that you might have the prediction right when the data is not changing. You might have the prediction right, but you might not know at all what you're talking about. Because, as we know now, the Earth is not flat, and it's not a disk held up by jaguars. So there's something there that it's like a kind of a warning that we need to heed. And people quite often think that, if we are able to really uncover the patterns in the data, like the Babylonians did and like the Mayans astronomers did, then we understand. But that's not true. Even though Hans Rosling is a very, very famous statistician and doing absolutely beautiful work, this statement is absolutely false. We cannot say that if we uncover the pattern in the data that we understand. I just gave you the proof in the first slide. We don't. But of course it helps, and I will tell you how things might work there. So there is this warning that we need to heed. If we look at the data, we can predict all kinds of things. Like we predicted that there would never be a Brexit. And we predicted that, well, we would expect someone else sitting in the White House. We were wrong. Many times Google predicted the outbreak of flu across the world by monitoring the kind of questions people were asking online. And based on that, they had these very smart algorithms looking at things, and they were wrong many, many times. And quite often, particularly about small tumors in mammograms, we were wrong in detecting them. We're just not able to detect them. Automatically, I'm talking about. And of course, we were wrong many, many times in trying to predict earthquakes, even though we have tons and tons and tons of data. So there is this really serious warning, be careful what you do with the data. And so you can do all kinds of cool things. Like, for instance, here, this is a record from 1990 up to the year 2000 of the out-of-hospital deliveries of babies that coincides with the number of storks. So here's your theory of birth, right? So it's the same kind of problem here. And here's another example which I particularly like myself, is the number of films Nicolas Cage appeared in and the number of people that were drowned by falling into a pool. I can kind of, relate to that. But the point, of course, is that there is this kind of correlation, but there is no causation whatsoever. It's just a correlation. And then you can go on like that. Here's the relation between the divorce rate in Maine and the per capita consumption of margarine. It's a total nonsense thing, of course. But it shows you that looking at the data doesn't tell you what's really happening. And that's I think, now actually everybody can leave because that's the main message I want to bring across. Okay, so what we're experiencing is what people are doing now with data science that we used to call machine learning, that we're now calling AI, which is all the same thing. Basically, we have data that we don't know exactly what it comes from. It's not designed in the way we want it to design. I'll come back to that later. We create this black box of tools, and then we infer patterns from that, and then we think that we understand. So the goal for today is to actually open up the box and see if we can do some things with that. Now here's a recent case of where things went wrong, and it went wrong in many, many places, but this is an example, particular example, because it's really easy to understand why it went wrong. So this is work by a guy called Rich Karuna, where he applied deep learning, so all the things that you hear about almost every day in the newspaper. Actually, this morning on Channel News Asia, there was a whole thing about deep learning and AI. So it's hugely popular. And this is where he used deep learning neural nets to study the records of 1 million patients and asking himself the question, if you have a history of asthma or any COPD, do you have a higher or a lower chance of dying from pneumonia? And if you think about this for 5 seconds or 1 second, you would say, you would not come up with the idea that the history of asthma would lower the patient's chance of dying from pneumonia. It would be higher. That's what everybody would expect. Yet, digging into these 1 million patient records, he found that it would lower. So if you already have a disease like asthma, then according to this analysis, this deep learning analysis, you would actually be less at risk of dying from pneumonia, which is totally nonsense. And the reason why this is wrong is obvious, because there was a hidden process. The people that had asthma were registered by the doctor already, and so the doctors are very vigilant, knowing that these people are very sensitive, so the moment they come in with some kind of sign that there is something wrong, maybe an indicator of an infection, directly started to treat. So you have a total biased data set there, and then you do these brilliant algorithms running over 1 million patients and just doing nonsense. And I wouldn't be worried too much about this, because this case is so obviously wrong that, why care? But the point is, nowadays, there is a huge amount of people that actually want to use these methods to come up with expert systems for medical doctors. And that's where I get a bit nervous. That's why I feel we really have to give some pressure against that, which is what I hope I'm doing today. So, Daniel Dennett is a famous philosopher. He just brought out a book, From Bacteria to Bach and Back, lovely title. And he said, if it, and then he talks about data science and machine learning and AI at all, if it cannot do better than us at explaining what it's doing, then don't trust it. So basically what he says, use your own brain. And I think we should. So, and the reason why these things go wrong are zillions of reasons, and I'll mention a few. One is that in the data that we have, you have to realize that people use this data that's out there, right? So they mine Twitter, they mine Facebook, they mine data sets of the city. But that data was not prepared with a question in mind. It's just a registration of what's happening. So there's a huge problem there, which is that it gives you a bias. And it gives you a strong bias. So particularly if you look in clinical trials, we know that there's a huge bias for, there's a majority is male. There's hardly any pregnant women in there. There's a selective, basically anything you can think of, it's selective. So, but yet we still use that kind of data as being representative for the populations that we work with. So we have to be very, very careful about those biases. We're very much aware of those biases. And again, I want to stress that the point is that the data that's out there has not been designed to answer the question that you have, right? So quite often we just dig into that data and then we try to find patterns from that and hope to find answers to the questions that we have. But what you should do, of course, is design a zero hypothesis or a null hypothesis. Then design your experiment, then look at your data, and then validate that. And that's actually not happening nowadays that much anymore, which is, I find, worrying. But things get worse. and it will get even much more worse. So here, the thing is that in these 3 publications that I definitely urge you to have a look at some point in time, it's a book by Peter Kutcher on the deadly medicines and organized crime, how Big Pharma has corrupted healthcare. It's an amazing story, and it will blow your mind. And then there's this paper, very famous paper by Ioannidis, who actually showed that most of the published research findings in medicine are false. And he has a proof of that. And so this is the data on which we build our research, right? The data that we use, the fundamental data that we use to build our research, is the data that is reported in literature. And he shows that the majority of that, he talks about 65%, is actually wrong. So that's pretty shocking. So that's what he says here. The most important data set, the conclusions of peer-reviewed studies, consist of predominantly bad medical data and cannot be relied upon, as they miss evidence of good experimental design, first principle models, and rigorous statistical analysis. And this is what he has shown. And this is very much in line with what Peter Kutzer also shows. But there, it's actually hidden by the pharmaceutical companies. So this is pretty shocking. So coming back to this remark of Dennett, use your own brain. Another way to phrase it is by one of my heroes from long ago, Robert Persick, who wrote this lovely book in Zen in the Art of Motorcycle Maintenance. And he said that, and this is a quote I absolutely love and I want to share with you. He said that the real purpose of the scientific method is to discover that nature hasn't misled you into thinking you know something you actually do not know. And this is it, right? The scientific method, the way we do science should be to actually figure out where we really understand what we think we understand. And I want to change this a little bit for this day talk to the real purpose of the scientific method is to discover that data has not misled you into thinking you know something you actually don't know. And that's what this is all about. So there is this black box where all these things are happening that I spoke about, and the goal is now to open that black box in some way and look into it a little bit more and show where things can go wrong and things can go right. And the main thing that we actually miss is causality, is actually have a deep understanding of how things are causal related. Of course, the examples I gave about the stork and the babies being born is the typical example where we have correlation but no causality. And that's so obvious for us because we are using our own brain. We know that things are not like that. But sometimes it's very hidden. And an example is in biology where you have this concept of circular causality, where ions are sucked into a cell through protein channels, changing the photovoltaic level. And because of that, the protein channels go open a bit more, and so they suck in more ions. So you get this kind of circular, you don't know where the things start. It's a circular causality. And we see that everywhere, and you will see that in examples that I will give on HIV and diabetes also. And this particular thing that I mentioned is called the Hodgkin cycle. It's totally causal relation, but it's circular causal relation. And again, just to want to share with you, there is this lovely book, also came out in just this year. This has been a good year for good books, by Dennis Noble, Dance to the Tune of Life. It's a lovely book that describes these kind of processes in life at large and biology specifically. So we want to look at the real world and not a kind of an artificial world in that sense. And then what we know in the real world is that the real world is complex, meaning that everything is connected to everything, which makes this causal relation, this causal connectivity so important. And so we know that in the real world things are not simple, right? And the moment we try to reduce things to the elements, the moment we look at the process, the moment we look at the disease, we take things apart, we look at the elements of that disease, we might actually lose what we're looking for. And this is one of the characteristics of a complex system. By taking it apart, you lose what you're looking for. And here's this beautiful example of these starlings here. And so you have this microscopic, beautiful pattern. But if you look at what's happening in one bird, you actually lose what you're looking for, which is this, microscopic pattern. And below is an example of the immune system, which we will hear more about later. And so the idea is that in a complex system, and you can translate that to your own research field, in your own practice field, in a complex system, the elements interact with their environment, they influence their environment, and then react to their environment. So again, there is this circular causality happening. And unraveling that is one of the biggest challenges, I believe, we have in science nowadays. It's one of the biggest things, and we see that everywhere, and we actually we're just starting to scratch the surface and trying to understand how to deal with this. How to really deal with this circular causality that's happening through complex systems. Now here's one slide with equations, which I'm just going to go through. It was not just to kind of show off, but it has actually a meaning. And I'll just give you this as a fact. What we know from complex systems is that they are so-called scale-free. That means that whatever level I look at it, I kind of see the same thing happening. And we can prove that with equations. We analyze patterns like that. And the message I want to say here is that because these complex systems are scale-free, we know that their variance might expand, but might explode, might grow beyond boundaries, and that the average actually doesn't exist. Talking about an average measure, some kind of observable of a complex system, talking about the average does not make sense. There is no average. And that's a shocking thing. If that is true, and I tell you it's true, so if complex systems, observables of complex systems, like diseases, if they don't have an average, then the consequence is that the more data I create, the more exceptions I create. And my learning algorithms will not converge. You know, if there's no average and I throw in more data, I will just throw in more exceptions because there's no average. I will not enhance that average, so to say. And so the learning algorithms, which is equivalent to data science, to machine learning, and artificial intelligence, mostly, will not converge, or might converge, but not to the thing that you want. So that's the point why in complex systems it's often very hard to talk about causality, because they are so much intertwined. And we see this is kind of a picture of showing that anything that's happening all the way from the atomic level via the molecule to the cell, to the organelles, to the organ system, to the organism, to the population, to the environment, all those things are intertwined. And of course, some of these things are, in huge different space scales or temporal scales. And you would say, okay, what the heck, what happened? How can I ever find something back in the environment, that's happening on an atomic level? Well, there is lots of things. So yes, this causality relation exists across all those scales, and not being aware of that is one of the biggest mistakes we can make. And I will give you an example in HIV where you actually see that things that are happening on the atomic scale will have a direct influence on the policy. So what I will do in the remainder of this talk, after kind of setting the scene, I hope, is give you two examples of serious diseases and how they how data can help us to understand things, but is not understanding the patterns in data actually does not help us that much. But what we need is a different way of looking at these things. One is the big question of pandemics, and the other one is diabetes, particularly type 2. So these two examples I'd like to share with you. And so let's start with epidemics, and particularly HIV. Well, before we get to HIV, this is an overview of the disease outbreak. It was published in 2014, and the thing that I found so shocking was not so much that the kind of big outbreaks happen more often than ever before, which is the left paragraph, the left panel, but also the diversity is increasing. So it's not just that we have more often outbreaks, like a big flu or whatever, but the diversity is actually increasing. And as you know, of course, Ebola was an example, but then all the kind of variants on that are still very much worrying us. So it's what we're facing is the product of these two, right? We're facing the fact that there are more events and they are more diverse. Now, HIV is, of course, one of the most well-known pandemics, and it's still, as you can see here, on the rise. And ignoring that would not be smart. And this is a graph from 2014, and you see that there's something like 35 million people worldwide infected with HIV. And this is very much an underestimate. And the reason why it's an underestimate, and the reason why we know that, is that many people just don't report, or are not reported, or are not even in contact with the healthcare system, or don't want to report. And all those things play a role. And so the expectation is that it might be even something like 10 to 20% more, which is even more shocking. So what I will do is I will actually take you through some research that we've done over the last 10 years, trying to figure out, can we actually make predictive models of this kind of diseases, particularly HIV in this case, and make sense of that. So in 2006, the European Union said, okay, if we want to spend €1 billion, so 10 to the power 9 euro, on stopping HIV in Europe, which is kind of a strange question because it's across the world, right? But then what we should do, should we spend it on better medicine, or should we spend that money on changing lifestyle? Now, if you think about that just for 5 seconds, I mean, you guys are working with these questions all the time, so for you this is not a strange question. For me, it was a total strange question when I first came across that. Because when I think about that, I say, okay, better medicine, then I think about, pharmaceutical processes, I think about chemistry, I think about cellular processes, I think about biochemistry, I think about, all those things that are going on there in the body. But if you think about changing lifestyle, it's about behavior. It might be about your social network, your social capacity, so to say. It might be about policies. It might be about... So how can you ask a question like this? How can I ever answer a question where I have to say, okay, use this money for this or for that? So we thought this is one of the questions that we will never be able to answer, so that's what we try to do. And so what we do need for that, and here I quote Nobel Prize winner Murray Gell-Mann, who was actually one of the founders of complexity science, who said, in order to actually understand what's happening in complex systems, and this is truly a complex system, is we need to have a crude look at the whole. Yeah. So it's again, because if you take it apart too much and you look at the elements, you actually lose what you're looking for. So you have to have kind of you sit in between, if you like. But after that, like I feel, you need to do is a detailed look at the parts, and of course have a good look at the holes that you left behind. And so that's what we're going to do for this particular example. So here's this is the world, as you might recognize it. And we are there somewhere. The research actually I'm talking about was done there, mostly in the Netherlands and with a consortium over Europe. And so this is the world, and if I would scale the different countries in the world with the incidence of HIV, then the world would look like this. So this is where the problem is, and it's huge. And if I would look at the amount of money being spent on research in HIV, and I would scale the world accordingly, it would look like this. I thought that was fun. So you see, where the money is not where the problem is. But that's okay, as long as we try to solve the problem where it is. And so it means that we really need to have a deep understanding of the disease in such a way that we can solve it on the locus where it happens. Now, HIV is a truly complex disease. And trying to find an answer to that European question is really asks for addressing it across its whole complexity, meaning all the way from the molecule to the policy. There is no escape. You cannot leave out things. The moment you leave out things, you really are going to miss things, particularly if you want to steer on it, if you want to do interventions. The graph here on the left panel shows you a bit about the complexity. So there's drugs we have, and I'll show you some of that. We start with the virus, then we have drugs to suppress the virus, antiviral combination therapy. But the actual inhibition process, we have many questions about that. The drug resistance, we have many questions about that. Then there is the immune response, many questions about that. Then there is the toxicity and the degradation of the drugs, many questions about that. So we know that all these processes are happening, and we know a lot about that. There's an immense amount of beautiful research done on this. But the more we know, we feel that also the less we know. So it asks for a kind of comprehensive, holistic description of all these processes that take place. And that means that we need to think about what's happening on what scale. There are processes happening on a molecular scale all the way up to the societal scale. And there's really no way where we can capture all these things into one model. I'm a modeler, as you might have figured out, and trying to model these things across those spatial temporal scales, as you show here, there is no computer in the world, even all the computers in the world connected together, that are able to do that. And you might ask yourself the question, will quantum computers be able to do that? And the answer is no. So there is no way we can actually model all those processes all the way from the molecular level to the social level. It's impossible. So we need to break it down in bits and pieces and see if we can make sense of that. And so here is a kind of an artist impression of the HIV disease, and it gives you a bit of a feeling of what we're talking about. And what will be shown, the green thing is the virus, the white thing is the white blood cell. And you will see the different steps of the HIV and the different inhibitors that we have for that. So the different drugs that we have available. So the first one was the attachment inhibitor. Then what is needed for the virus to actually start to melt with the white blood cell is the thing which is called co-receptor binding, and we have actually nowadays also drugs for that. So there are two receptors that are needed in conjunction. And then there is a fusion process that actually melts, if you like, the whole of the virus with the white blood cell. And then if all these things fail, if all the drugs that I was talking about fail, then what will happen is the virus will be released into the white blood cell, which is happening here. And it's actually just coding the white blood cell. This is just a piece of code, right? It's just RNA, particularly, that's in there, with a couple of proteins that take care of the processes that are next. So, but for that we have things like inhibitors again. There is this thing which is called reverse transcriptase, and a very important molecule, that I'll say a few words more about later. Because what the cell needs to do, it actually needs to translate the RNA of the virus into DNA. And when it's successful doing that, it will actually plug it into the cellular DNA, right? And once it's in the cellular DNA, the cells will start to replicate and also copy that piece of code that was given by the virus. So automatically it starts to replicate the virus. And that's the whole process that most of you probably already know is happening. And then these virons come out of the cell, or actually come out of the nucleus. And then they are assembled together, again with the proteins that were already present in the virus. And they are assembled together, and for that we have again a drug, which is called the protease inhibitor. And if that drug also fails, so all those drugs that I was talking about, if they all fail, then they reassemble into virus particles. And not just one, but many. So what happens? That after a primary infection, patients are ending up with 10 to the power new virus particles per day. So there's 1,000 million new particles, viruses per day. And the problem now is with HIV, as you probably well know, is that one of these molecules, these reverse transcriptase that I was talking about, and that's the molecule that translates from RNA to DNA and then allow for the plugging into the nucleus. It makes mistakes doing that. This is kind of a stupid thing. So it tries to read RNA and then write DNA, and then every now and then it makes a mistake. And that's the way we get those mutations. And most of these mutations will just actually result in viruses not being constructed, but some will actually construct viruses, and then our drugs won't work anymore because they were targeted at a particular chemical signature which has changed. And that results then in resistance. And even a few mutations already gives us, like 3 mutations gives us a 10-fold resistance on the drugs that we have available. So there's a huge, huge challenge to actually see if we can solve these things. And then nowadays, there's still about 10% of the people infected with HIV are actually living with drug-resistant viruses, and we don't really have a solution for that. Good news is that the cocktails that we have, in most of the cases, actually allow you to live very long. So nowadays, the drugs are very, very good, but having those mutations do impose a big challenge. So if you want to understand this whole thing that I was talking about, you really need to go across all those different spatial temporal scales. And so here's the thing, what we did, this is a molecular simulation of one of the drugs, and in particular this is the drug sequinavir that interacts with protease. Protease was one of those steps where the virus is constructed in the cell. And so what you see here is this little thingy here that actually escapes. So the big thing is the protease molecule. The red dots here are the kind of active sites, and this is the medicine. And the medicine should actually stick to that red thing. And once it sticks there, and remember, like for instance in the case of reverse transcriptase, it wants to transcribe from RNA into DNA. Now, the moment you block that active site, it cannot transcribe it anymore. It's exactly what you want. And the same thing happens here. If you're able to block the active site of the protease, then by this molecule, that's it. It's just like toy. It's like Lego what we're playing here. So, so you actually want to block this active site there. And if you're able to block it, then the molecule will be inactive and it will actually not operate anymore. But what you see is if you just add a little bit, and that's what we did here, we actually added at these numbers here different mutations, this spaghetti thing, which is actually the protease. We added different mutations, and the moment you have such a mutation, that particular drug will not work anymore. That's what's shown here. It actually walks away. It doesn't stay it doesn't stay put. So that's an important thing. And so what you want to know is this binding affinity. How good does that molecule bind to that particular site? And that's almost a quantum mechanical calculation. It's the lowest we can get, right? And so, in terms of space and scale. So binding affinity is the thing that you want to remember, because that's the thing that measures how good your drug is actually. And I'll get back to the binding affinity later on. But the next thing, so this first simulation I showed you was done with basically solving Newton's equation, using big computers to do that because it's a pretty complicated problem. But in the end, we are able to do these things. We are able to accurately calculate that binding affinity for each drug and for each mutation for each patient. Which is what we're doing actually while I'm talking. We are running those programs all the time. It's work we do together with UCL in London. And the next thing you want to do is actually try to understand how the virus enters the white blood cell. So there's this thing about the co-receptor I was talking about and the fusion process. And that we were able to model, and I'll just give you the results of those research. I'm not going to the details, of course. But that we were actually able to model using a thing which is called an agent-based model, which is a kind of a higher level description. It's not on a molecular level, but it's a kind of a higher level description. And all those steps that I talk about, we can validate against experimental data. So you go out, we talk to the medical people, we talk to the biologists, we say, okay, this is what we find through simulation, and then we go out and do experimental tests to see if we actually are doing the right thing. So step by step, on each scale, on each level, we do validation. And then, of course, there is the immune response, which plays a major role in, helping us to, we are here, right, because of our immune system. 350 million years of evolution actually gave us this adaptive immune system, and protects us against all those pathogens that we are being attacked by. So here's an example of a patient. The black dots are the virus particles and the primary infection. And you see this huge lump coming in here. So that's this 10 to the power new virus particles per day building up in the patient. And these white squares is the immune system. It's actually the activity of the immune system. It's CD4, CD8 T lymphocytes. And then what you see is actually that the immune system gets a hit, but then it recovers, and then the virus basically starts to disappear. If it would stop here, it would be like the flu. Your immune system just took care of the whole thing. But it doesn't stop like there. But all kinds of things are happening which I cannot go into, unfortunately. But what's happening is the virus actually starts to hide. It sheds off all kinds of molecules. It's not recognized by the immune system anymore. It starts to hide in the lymph nodes. And then the immune system slowly starts to collapse until there is this third phase, which is the AIDS phase, where all kinds of opportunistic diseases pop up. And then you die from a very simple bacteria infection. So this is the primary phase, the clinical latent phase, and then the AIDS phase. So, of course, what you want to do is make a model of that. Try to understand how the immune system is doing these things. And we spent quite some time, and we're actually able to do that using yet another technology, which is called Cellular Automata, which is yet another higher level description, taking you away from the molecular level to, in this case, the activity level of the immune system. And again, here you can validate that with clinical data, which is what we did. But then, you have to get out of the body, because in the end, it's, the majority of the problem comes from sexual transmission. So you want to understand how the virus and how the steps that I was talking about before, how that will actually transfer through the networks. So for that is an interesting question, and that is, do we describe those networks, and how do we describe those networks? Now here is an example of a network, and I need to bring this across to you because it's a crucial element of the way we try to model things nowadays, particularly the way we try to model complex systems. And so this is a high school dating network. Okay, so the blue ones are the boys, and the red ones are the girls. And this was done through interviews, asking, whom did you date over the last 3 weeks? So it's pretty active high school. So you see there are some very happy boys here. There are some pretty active girls also. I think I was somewhere around here myself. But you get the idea, right? With this very simple graph, you directly understand how we can actually describe with those graphs interconnections between individuals. And of course, these graphs change over time, right? If you would do the same experiment, you would ask again, about this dating, you would ask again a year later, it would look totally different, probably. So but the question we're asking ourselves when we're talking about the transmission of viruses, or ideas for that matter, because you can have a social network that looks like that and actually can also propagate ideas. I hope you understand the link that I'm trying to make now. But if you would look at viruses, then the question is, okay, if there would be a virus, could be influenza, how would it actually, go through it? And in this particular funny case, you could say, this guy has influenza, and if a connection would mean that he would infect someone else, that by the time he's recovered, it gets back to him. So there's all kinds of funny things that you can actually distill from this. But you got the idea, right? So what you want to do is you want to look at the dynamics across that network and the dynamics of that network, because it changes over time, which makes it hugely complicated, of course. But nevertheless, you can try it. And these things get more hairy. This is one of the famous hairballs of interactions. But you got the idea. And the question you want to ask yourself is, okay, how are these things connected? Now, there was this old idea of so-called small world networks, which would mean something like, you probably heard about this 6 degrees of separation. That means that everybody in the world is just 6 handshakes away from everybody else. So I know Lera, who's sitting here in front, she's 1 handshake away from me. And she has someone who knows someone who knows someone who knows someone. And within 6 steps, I will be able to reach anybody in the world. And that has been tested a couple of times, and so we feel that might be true. So this is me at some point in time. This is Medvedev, whom I at some point was able to meet. So I did shake my hand with him. So he's 1 handshake away from me, and because of that, Barack Obama is 2 handshakes away from me. Right? So after this, you can shake my hand, and then you know where you are. But the consequence is also Donald Trump is then. Okay, so this is the idea of small world network, right? But networks, well, they're not always like that. So people started to look into that a couple of years ago, like 10, 15 years ago, and they found that when we look at networks, we expect something like this. And so forgive me that it's a bit technical, but it's pretty easy to understand. What we expected from networks is that they would have an average. So that the connectivity, so the amount of people connected to me, if I look at the amount of people connected to you, to you, to you, and I'll just summarize all, then there will be, one with a peak, and then there will be few which have many connections, and there will be few which have few connections. So you would expect, as you always expect in biology and science or whatever, that it would be forming this bell curve. So again, this is the connectivity, and this is the probability of having so many connections, and you expect to have an average. But of course, I already primed your mind by saying complex systems don't have an average. So you now already know the answer. This is not happening. What's happening is this. This is the way those networks are looking. So this actually says, although this is on a logarithmic scale, but this actually says that there are very few with a very few amount of connections. There are many of those, and with the many connections, there are only few of those, and so there is no average. Right? And this is what we observe in all kinds of networks, whether it's social networks, whether it's protein-protein signaling networks, whether it's gene regulatory networks, whether you name it. We find this kind of scale-free networks everywhere. Let me see if I can still do that, right? And we also find them in opinion networks. And we can actually study the dynamics. You see something happening there. We can study the dynamics of how those networks evolve over time and how opinions move through that network. And then, because they move, they change the network. So again, there's this causal, circular causality happening there. And it helps us, for instance, the rights panel is what we did ourselves, where we studied the interaction of the molecules of your immune system with the molecules of the HIV virus. So we actually looked at how those networks evolve over time once people are infected with HIV. And again, they all have this kind of same interesting characteristics. So, in order to understand the spreading of the virus across a sexual network, we can actually use those networks. So what we did is we went to the Center of Disease Control in Atlanta, and we dug into their data and trying to understand if trying to find data that helps us to understand the networks of homosexual and heterosexual populations, which is what we were able to do. And we actually came up with network descriptions for the heterosexuals that look like this and homosexual. So this tells something about the connectivity, and this tells something about the amount of sexual interactions, a maximum in this case, per year. And so we have pretty reliable data nowadays on this. This is on a total population of the United States. And so once you have these things, then we just rev up our computers, we generate those networks. Right, because we know those numbers now. So we generate the networks, we inject the virus in the networks and see what's happening. So that helps us to actually predict how that virus will go through those networks. So here you see how models and data suddenly start to really feed into each other and actually try to building on first principles. And you can do things like trying to understand how different social aspects as age and sexual preference, etc., how that would lead to segregation of those networks. And here you have segregation, homosexual, heterosexual, and drug users that we studied. And then what we did is we say, okay, now we need really accurate data that is so accurate, giving answers to particular questions that we can now ask. And there was this study done in Amsterdam, the Amsterdam Cohort study, which is about 2,500 people, homosexuals particularly, which were followed over 25 years. And we know a lot about that. We know a lot about, of course, their genetic profiles, if you like, but also their social profiles. We know things about sexual behavior, etc., etc. So that really is a data trove to study these models. And that allows us to do things like this, is look at what moment in time seroconversion took place in those populations. IDU is intravenous drug users, and MSM is men having sex with men. And so we could actually see how there is a segregation in terms of early seroconversion versus late seroconversion, and how that actually creates subpopulations as you can see here, and subpopulations, as you can see here, in those networks. I'll skip this one. And then what we did is combining that with the phylogenetic structure of the viruses. So for the virus, you can make a profile, like you can make of the individuals, how they are connected together through the sexual networks or the dating network that I showed you. But you can do the same thing for viruses. You can actually make out a dating diagram for viruses, which we call a phylogenetic tree. And that gives you actually how viruses, how the inheritance of viruses goes about. And then if you combine these things, then again we find these scale-free structures. So that means that we're definitely on the right path, and that we now have a better understanding of how these viruses sit in those networks. And then combining all those things that we have, so knowing if someone is treated with something that blocks the reverse transcriptase, and we can calculate for the particular patient, knowing his mutations, and we can calculate the binding affinity, then we know what is the likelihood that he still is able to transmit that virus, because the binding affinity will tell you what will be the viral load in that individual. And the higher the viral load, the higher the likelihood of transmission. And so then if that individual sits in that network, if he's isolated, well, that doesn't matter so much. But if he's very much a hub, then he can spread it much faster. And then actually you can already predict, and that's what we did, you can predict at what point in the network what strains of the viruses will pop up at a certain point in time. And you can do that with pretty high accuracy. And this is done in different cities. We did this in Amsterdam, we did it in San Francisco and in Berlin, looking at how a prediction, the red one is the prediction and the blue one is the data, of the spreading of HIV. And of course, and then you can do what-if questions, because the blue one is the data, but the red one you can play with. You can say, okay, what would happen if? What would happen if I have a slightly better drug? What would happen if I was able to change behavior? Right? And then you come already a bit closer to finding an answer to that question that the European Union was asking. And so looking at the total population of HIV, we were actually pretty accurate. So here you see the outbreak of HIV that happened around the 1990s. And the red one is, the blue one are the data points, and the red one is the simulation. So taking all those things into account that I was talking about, all those different scales and levels, we were pretty well able to predict what's going on in HIV. And then you can combine all those things together. I'll just skip this for a second, because I want to come back to one more example before you all fall asleep. I want to make sure that I get another example across. So anyway, this is what we're doing in HIV, like I said, all the way from the molecular level to the transmission level. So the answer to the European Union question was, they asked us, where should we put our money, in better medicine or changing behavior? And the answer is, by far, it is changing social policies that do change behavior. That is by far the best intervention you can do in the case of HIV. And another discovery we had is that actually that the ones who are mostly connected seem to be also the ones who are having a longer untreated period, which is a very interesting observation. So that means that if you are connected to many, many other people, most likely you're also the one who is kind of underreported, which is kind of special. Some results there, okay. So the second example, and I will go very quickly to it, but just to give you one more message, and then I will sum up. The second example is diabetes, and as you know, it's a pandemic, and it's getting worse and worse and worse and worse. Increase of 50% over the last couple of years. Singapore also has its problems, as you probably know. And we see an increase everywhere. So the red ones are from 2010 and 2004. The green ones, we see an increase everywhere for every age population and every ethnicity and every gender. So yes, it's there. It's a problem, and we have to deal with it. And again, of course, it got all those components, right? It has this physiological, clinical components, but it also has the social and socio-economic components in order to understand that. Now, one message that I need to bring across is that hallmark of type 2 diabetes is that because of this systemic, I would say, energy overload, that actually what it does, it triggers, of course, triggers your metabolic pathways, just get rid of the fatty acids, if you like. But at some point, we have too much, it starts to trigger pathogen pathways. And these pathogen pathways actually can then get rid of some of this additional food that you have. But at some point, they cannot deal with it anymore, and then it triggers the immune response pathways, which is basically saying that you, at that point in time, have an inflammation. So diabetes, or overeating to some extent, just creates inflammation. It's actually a oxidative stress that you give to your body. And if you do that for a long, long time, then your immune system is not able to cope with other things anymore, and so you have a serious problem. It's almost comparable to this, long-term infections with HIV, in the sense that you are overcharging, activating your immune system. So that's the thing, it induces inflammation. So what we did is we had a design study where we had 25,000 patients, people, not patients. We had 25,000 people where we looked at Surinamese, African, South Asian, Turkish, Moroccan, Ghanaian, and Dutch ethnic backgrounds. And we looked into some depth, so we also looked at, not just the individual, but also his parents or her parents and the siblings, but also his children and partners. So we create little tiny networks and then looked at lifestyle, behavior, social and biological factors, clinical factors, or whatever you have. And then we also connected that with geoinformation. So things like, we have particularly looked at about 5,000 unique post areas. And we looked at things like travel, traffic noise, childcare facilities, income, education level, etc., etc. Just because we realize that diabetes is not just a very simple, molecular process. Yes, it's that, but if you want to do intervention, you need to look also at social, economical, and even urban situations. You cannot disentangle them. Again, if you take them apart, you lose what you're looking for, which is a definition. Anyway, so then we spent about a year and a half with 5 people talking to social workers, talking to medical doctors, clinicians, people like yourself, talking to anthropologists, etc., etc. And everybody was saying, yeah, but you forgot about this. Yeah, but you forgot about that. Yeah, you forgot about that. And we said, okay, just give it to us, right? And so we just got all those parameters, all those determinants that all those different disciplines came up with. We put all those determinants together into this kind of maps, where we look at things like we understand, okay, there is an aspect, for instance, here, there is this social, there's a family that plays a role, there is things that medicine intake that play a role, there is sex-specific things, there is ethnicity things, etc. So you just try to make a map of anything that anybody wants to say about, what plays a role in diabetes, right? Since we don't discard anything. And of course, we also look at the molecular processes in the body itself, which I will skip because of the time. And we were able to actually model these processes in the body with with agent-based models, and this is very much validated. But then the trick is, once we validated this, so here, for instance, you see an example of this validation. We see how the antigen and humoral responses after systematically overeating, a higher calorie intake, how that will actually spawn off all this IgG and IgM, which then are triggers of inflammation. So we can actually predict this. With these models, we can predict. You can say, okay, if you eat this, if you eat so much of this, and there are so many PUFAs, which are these polyunsaturated fatty acids, if there are so many PUFAs in your diet, we actually can predict how, over time, you will trigger the macrophages to change into something which will actually be systemic inflammation. Okay, and then we thought, okay, now we need to bring all these things together. You see the pattern, right? It's almost the same that I was talking about with HIV. Again, we try to bring these things together now in one big model. And what we're doing there is actually taking a system dynamics approach, which is a very simple approach. And I just spent 10 seconds to explain this to you. So the approach, assume that this is like a population dynamics thing. So here's the population. The ingrowth of the population is determined by the amount of people being born, and the outcome is the amount of people that die. It's that simple. So that's what the system dynamics model does. So it actually measures, what comes in, it measures what comes out, and then it looks at the dynamics of that. That's the whole thing. But of course you can make that more intricate. connecting all those things together. And that's what we did. So we took all those things that I mentioned before and then connected that in this kind of causal maps. So here we have the causality connections between all those things that were in the previous slide, connecting these things together. And every arrow here has been debated seriously. And so we're pretty sure that this actually is a good representation of what's happening from the physiological level, the early exposure, the social determinants, the population level, and comorbidity aspects. But of course, this is way too hairy to study. This is too many parameters, it's too complicated. So you want to simplify it a bit, and that's what we did for this particular case. And given that I don't have that much time, but I give you the result. So I can play around with this. This is just a thing where we look at things like the relation of your salary. So if you have enough money to spend, if you don't need to worry every morning about giving your child food, so you have enough money to spend, for instance, on going to gym or Pilates, for that matter. So you have enough money to actually work on your health. That makes a difference, right? And if you have less money, that also makes a difference. And so you can actually then correlate things like salary and income to things like stress. And you can actually quantify that. And then, because of the stress, which is an inflammation signal, that will then influence your BMI again. And so what we already discovered, and I thought that was pretty cool to share with you, is that we already found by just a little bit of changes in the salary and the stress perception and the stress, actual stress, you already come to this bifurcation of two possible weight regimes. So you might end up in a regime which is a high weight, and you might end up in a regime which is a low weight. So it's hugely sensitive, right? It's almost like the famous story about the butterfly flapping his wings in Barcelona, in what is it, in Brazil, and causing a thunderstorm somewhere else in the world. It's very sensitive. Little changes in those parameters actually will predetermine you one way or another. And then we actually looked also at more feedback loops, like if you have an app that monitors your health, that actually will influence your health. Just by the fact that you have that app, you will be more aware of what you're doing, etc. And this is work done with Cillian, who's somewhere in this audience also. So in a nutshell, the data that we have there's enough. I don't think data is the problem, in the sense that there is not enough data. There's more than enough data. There's more data now that we generate every year than there was ever before in the whole of human history. So that's not the issue. But of course that data is, it's not, the data that we have access to is not the ones that we designed to have. So there is no null hypothesis behind it. There is no structural thinking behind it. It's just there. So are there fundamental limits to data? Well, there's this curse of dimensionality. Problems become intractable the moment we increase the number of variables. And so a large amount of information makes it easy to find all kinds of beautiful patterns which are meaningless, right? The ones that I was talking about. And there is this issue of scale-free power law dynamics, meaning, again, like I said, that more data will actually give you more exceptions and will not help you to actually deeper understand things. So that means that we're actually hitting it for a kind of a clash of two knights of science. One is Francis Bacon, inductivism, saying there's a crow, it's black, there's another crow, it's black, so all crows are black, which is data science, right? Or Popper said, let's do an experiment. And what we need is, of course, the merger of these two. We need the merger of this kind of two philosophies. So, conclusions, data is dead. Meaning it's dead without what-if models. And it's dead because it's a record, right? It's not a conclusion. It's not an insight. It's not a solution. Data analytic predictions work well only if the future is fundamentally like the past. Well, if that would be the case, we all would be dead. It's not, right? The future is not like the past. So that doesn't work like that. And big data leads to radical empiricism. Basically, what I was talking about before. It denies the possibility of knowledge. Was already, a philosopher talking about that many, many times. And then we need to take into account these different causality things that I was talking about. There is no way we can reason about diseases and interventions without looking at the whole and looking at all how these things are interacting with each other. And system dynamics might be a way to actually do that. A beautiful quote that I would like to give you is I have one more slide. A beautiful quote is from Dick Feynman, who is a Nobel Prize winner of physics. really famous person who said that what we need to do is we need to stop and think about the complexity, the inconceivable nature of nature. So we really need to think deep about those problems. We cannot just get away by looking at one aspect and forgetting all the other aspects. That's the main message, I think. So these are all complex systems, and the question is, can we model them? Here it is one of the slides that I showed you in the beginning of this bird flock, where you have this macroscopic beautiful patterns and there's all these interactions going on. And actually what you can do is you can look at what one bird is doing. It's trying to escape from its neighborhood. It's just 3 simple rules. And then with these 3 simple rules, you can actually create that thing. This is a computer simulation. This is now not a record of real birds, but this is just a computer simulation. So can we actually model those complex systems? I think we can. Thank you for your attention. Thank you.
So we now take questions. We have a number of questions from Facebook live feed, and I'm sure many of you deal with questions as well. We have mics to set it out, so Paul actually, feel free to walk to the mic and ask the question that you have.
Don't be shy. Excuse me?
I'm Zach from NTU Economics. I'm just wondering about the policy making aspect of this complexity science. Given the limited time scale which policymakers might have in making policies, what is the scale, the time taken for you to conduct such a study in order for you to influence policies? Yeah. So I'm just thinking about that.
That's an excellent question. So if I can repeat the question, first of all, you're from economics, right? So that definitely has an angle to it. So the question is the timescale of interventions, right? How we choose them, particularly policy interventions. The thing with policy interventions, as you know, that they take a long time to evolve. But what we see nowadays is that public pressure actually leads much faster to policy changes than ever before. So, for instance, in Europe there was a case on intervention strategy actually for HIV. And because of public policy, they implemented it because of public pressure, they implemented the policy much faster. But it's a very good question. It's about, you might be, so the system is in some kind of dynamics. You want to decide on that what you want to do, like in economics. You want to decide on what it's going to do, and by the time you're going to do it, it already changed what it's doing, right? So you have to kind of get in resonance with the dynamics of the system. And so it's an excellent question, but I think through these simulations and through this data analytics to some extent, we are able to pinpoint what is the timescale of that kind of intervention. But it's a very important question. Also, the whole question on how do you deal, for diabetes, economics plays a very important role. So we have actually health economics people working with us on reasoning about these things. Yeah. There's a mic somewhere.
So the first part of your presentation told us there is no average, no mean value. Yet in the second part, in the diabetes modeling, you actually build it for some average model, right? Average person in this dynamic model with its stocks and flows. Apparently there was just like one constant for a model for each of the errors. So how do you plan to develop it and personalize?
Yeah, so the last word you say is the most important one, which is personalization. So the model we built is an aggregation of all kinds of, so I said we had 25,000 individuals that we studied. So we didn't take an average of that, but we looked at all the characteristics, all the attributes of individuals. And from those attributes, you created let's call it an agent that has those attributes, and then for each particular individual, we can say, okay, for this particular individual, that agent has that characteristic activated and that characteristic activated. So it's not an average, it's an aggregate. It's an aggregate of all possible all possible attributes that you can have as an individual. And so it's absolutely not an average. You can actually do it on an individual base.
So you can tell me my constants.
If you were in there, of course I could. Yeah, sure. Yeah. You're not in that trial, I think.
So I have some questions from Facebook as well. For diabetes research, how do you decide which factors to focus on the long list of determinants obtained from healthcare professionals?
Yeah, so it's not up to me to decide on that. So what we do is we work together with the Amsterdam Medical Center and the UCL in London, and we provide them with these models. And then what we do, they say, okay, what would happen if we do an intervention here, right? And then we just look at the outcome in those models. And then they say, okay, well, so we do this, what we call sensitivity analysis. So some interventions you might want to do, like say, okay, the most easy intervention is give everybody enough money, and make sure that they can go to fitness, to the gym, force the people that produce food to have less fatty acids in there, etc. So, but these things might not be realistic. So you always have to have this trade-off with what is realistic and what is not realistic. Now, the cool thing about those models is, when they are validated, that we can actually do the sensitivity analysis. Say, okay, if you have this whole range of interventions that you think that are possible, then we can play with those and say, okay, this one has the best result. But this is on a case-to-case, on a country-to-country, and even on ethnicity to ethnicity. And for instance, in Europe, we have these epigenetic effects of the war that's kicking the war. I mean, the Second World War. So the Second World War was a nutrition poor time. Now we are a couple of generations later, and that actually has epigenetic effect. Because of that, we have people storing more fat than ever before. So here is a different situation, so to say. So the model allows you to play around with those questions.
So I know that you've mentioned that there's going to be no shortage of data, but I'm an HIV physician, and one of the major problems we have is that we have hidden populations that we cannot make any predictions about because they're just hidden. We have no opportunities to collect data from them. For example, drug users in the local context, for example. So how do these nodes of missing data, how do they factor into the models that you then create to try and, because eventually they're going to reach the level of policy, and if you miss out on this data, then you miss out on the opportunity to intervene in these populations as well, who may actually be major hubs. So how do you address issues?
Yeah, things we do not know, we do not know. That's and it's an excellent point. There's all kind of hidden, people that hide are away from this data. But the point is, we were actually able in another study, and this has got nothing to do with health, but it was got to do with crime and crime networks. We were actually able to uncover crime networks that were totally hidden by looking at some of those that were not hidden. So because they're all part of one network, some of the network is dark, and some is not dark. By looking at the dynamics of the not dark, of the white network, as we call that, we could actually infer the elements of the dark network. So there's really a lot of things you can do there, and that might help you, because then you suddenly might know, okay, if these three individuals are there, then and they do this kind of thing, then I can expect that is happening there. For instance, if you look at HIV, if you look at the phylogenetic tree of those three individuals, you can do already contact tracing, right? So you might be able to find that individual hidden there. So it is not that hidden information is totally obscure. We can still get our hands on it. We can still find signatures of that in the white information. But it's an excellent question. Yeah.
So we have quite a number here. This is a bit of a naughty one. If we have to be skeptical about causal relations in scientific inquiry, to what extent is the evidence collected and presented here credible? Yeah,
so the main message is that looking for patterns in data is not enough, because patterns don't tell the story. Like the number of storks don't tell the story about how babies get born. But that doesn't mean that you're hopeless. The thing is, what you have these a priori models that you can plug in and then ask questions to the data. And so the models that I was speaking about, that's the whole message, I think, is those models, they describe the causal relations on a low level, and then they interact with other models on a higher level. Like, for instance, the example was giving about the binding affinity. So the binding affinity feeds into what's happening on your immune system, which feeds into the viral load, which feeds into the transmission network, which tells you what is the likelihood that a certain virus strain will go about. So there you can have that kind of causal relations, because you have and then at each level of those models, you need to ask questions to the data. So the point I'm making is, don't just trust the data, but make your model in such a way that you can ask the right questions to the data, or even ask the experimental people to come up with the right data, or do the right experiments that can validate your models. So yeah, it's a good point.
We have time for a couple more questions. So how do we start to understand a complex system if we, given its complexity, and we're not quite sure what the things there are in that system?
Yeah, so that's a question I get a lot. So if a complex system is really complex, well, can we ever solve it? There are basically three things. One is you want to predict the dynamics of the complex system. You want to understand where it's going. And second is you want to interact with it. You want to do interventions or control, if you like. And if all these things fail, you want to know what you have to do next. Right, so this the three aspects, and I think so. I think the biggest problem of complex systems is this particular aspect of control, of trying to get control, and this is a huge research field, the controllability of complex systems, and that goes also for interventions in diseases, and the current results, and this is really hot. I'm talking about like last year, 2 years, or something like that. Is that interventions in those complex networks should not go by it should go by very small nudges of the system. And the reason why you do small nudges of the system is then you actually allow the system to recover. So you give a little tick to the system, you allow the system to recover, you give another tick, and that way you can actually steer it in a particular direction. Because the whole reason why we want to do these things is because we want to know on what determinants of the diseases do I need to intervene. So, and then I want to know how much I need to intervene in order to get the effect. So this whole controllability is a big issue. But we're slowly getting. This is a very new science I'm talking about, right? I think it's something like 20 years old or so. So, and particularly this question is just very recent. Yeah.
So I'll ask the last question. So in John Holland's book Hidden Order, he talks a lot about theory. How should we fashion into theory? How should we fashion theory into the questions that we have with regards to the situations of complexity that we're trying to understand? What is the role of theory?
I would put it slightly different. I think what is the role of models is if you allow me to rephrase your question. So the whole thing is, all the people as you sit here, you have this huge amount of experience, a huge amount of hidden knowledge, and some of that is really hidden. You hardly know that you have it because you're using it on a day-to-day basis. And so the goal is to actually get that out of your mind and incorporate that into those models. And so I guess where most of the fun is, and also most of the challenge is actually to sit together with the domain experts. Like I spent 15 years with HIV experts, and now the last couple of years with diabetes experts, to sit together and to try to speak each other's language. And complexity science is a language that is relatively easy to understand for everybody. So once you have a common language, then suddenly you can understand each other. So I think that's one of the biggest advantages of complex systems. So it's not difficult to talk about networks. You know, everybody directly understands what we mean with it. And a couple of steps deeper, you also directly understand what it is. So the models and the theory that we have for complex systems are like a lingo that we can use to communicate between the domain experts and the people that do the modeling. Yeah.
We've come to the end of today's Sumo meeting. Could you put our hands together to welcome?
Thank you.